meeting to order.
Welcome, everyone, and thank you for joining us for this meeting of the California Technology Assessment Forum, CTAF, a core program of ICER. My name is LaWanda Grisette, and for this meeting, I will be serving as the acting chair as we discuss calcitonin and gene-related peptide inhibitors and their role in the treatment of migraine. At this point, I would like to begin by, as we do with every meeting, asking the members of the CTAF panel to introduce themselves, their roles, and I will start. I'm LaWanda Grisette. I am Director of Advanced Heart Failure and Cardiomyopathy at USC.
I'm Bob Collier. I'm with a group called Patient Advocacy Research that we started about 30 years ago, specifically to get patients integrated with the research process.
Dr. Gregory, before you go on, and I also like to ask for anyone, we have a process of disclosing any conflicts of interest before the meeting, but if there are any updates to the COIs that have been provided, please let us know about that. Bob, do you have any?
No.
Thank you.
It's going to be exciting meeting. Competing next door. I'm Kimberly Gregory. I'm Vice Chair of Women's Healthcare Quality and Performance Improvement in the Department of OBGYN at Cedars-Sinai Medical Center, and I have a joint appointment at the UCLA School of Public Health. And I have no updated conflicts.
I'm Joy Melnico. I'm a professor of family and community medicine at UC Davis and director of the Center for Healthcare Policy and Research there, and I have no conflicts of interest.
I'm Patricia Powers with the Center for Health Decisions within UC Davis's Policy and Research Center, and I have no conflicts of interest.
Good morning. My name is Jeffrey Hotch. I'm a professor of health economics at the University of California at Davis, and I'm the associate director of the Center for Healthcare Policy and Research. No updates on the conflict of interest.
I'm Michael Steinberg. I'm professor and chair of radiation oncology at UCLA and director of clinical affairs for UCLA Comprehensive Cancer Center. No conflicts.
Robert Rentschler, and I'm a retired medical oncologist. No conflicts.
I'm Bill Remack. I'm a retired medical technologist and chairman of the California Hepatitis C Task Force, located in Petaluma, California, and I have no conflict of interest.
I'm Alex Smith. I'm a physician researcher in geriatrics and palliative care at UCSF, and I have no conflicts.
Say Lee, physician researcher in geriatrics at UCSF.
Felicia Cohn. I'm the bioethics director for Kaiser Permanente Orange County and a clinical professor at the University of California, Irvine. No conflicts.
Jeff Klingman. I'm the chair of neurology at the Permanente Medical Group, and I have no conflicts.
Thank you, and I have no conflicts to disclose as well. Throughout the meeting, we will be asking all speakers to specify their conflicts of interest. Joining us today on the panel, we also have clinical experts and patients, and I would like for you also to introduce yourselves, starting from your left, your right, actually, and specify conflicts of interest and your role in the meeting, as well as what you do outside of here.
Good morning. My name is Jill DeLynn. I'm a registered nurse, and I am a patient advocate. I work with the National Health Foundation and the Coalition for Headache and Migraine Patients, as well as the Alliance for Headache Disorders Advocacy.
Thank you.
I'm Kevin Lindberg. I'm the executive director of CHAMP, the Coalition for Headache and Migraine Patients. Our funders include some pharmaceutical companies, for disclosure.
Hello, I'm Sonia Petrevic. I am the regional headache specialist for Southern California Preventive Medical Group, working here at Los Angeles, and I'm an expert reviewer.
Hi, Yvette Young, neurologist and clinical lead at Healthcare Partners Medical Group.
also a Kaiser and USC alumni for training. I have no conflicts of interest.
Thank you. This morning and throughout the meeting, there will be opportunities for question and answer, and I would ask that the panelists indicate whether or not you have a question by turning your label as so, and I will try to go in order. I have one more introduction to do, and at this time I would like to introduce Dr. Stephen Pearson, President of ICER, who will describe the background and mission of ICER and CTAF.
Thank you, Luanda, and thank you for being our chair today. Hi, everybody in the audience. Thanks for joining us, and those of you on the webinar. We're very pleased to have our patient experts and other stakeholders here with us today. There we go. So I'd like to start off with just a very brief introduction to why we are here today, what the goals of the meeting are, and a little bit about the background of the report and the deliberation structure that will be the focus for today's meeting. So why we're here today is that, again, we are faced with the pleasing prospect of real innovation that's going to promise substantial benefits to patients, their families, and the community. And I have a couple of quotes from those that we received during public comment. One here is about this, again, this brings up the issue about how serious migraine is for many individuals and for us as a society. This quote says, "You lose your sense of who you are, how to speak, how to think, how to move. You become a shell of your former self. The light hurts, that woman's perfume on the subway makes you sick, the sound of a baby's cry sends you into paralysis." That was one patient's comment. Another said, "I'm terrified of the day when I won't be able to work, as I have to spend so much money on medications and doctor appointments just to get out of bed that there's no way a Social Security disability income would support me, let alone my family." This gets at, again, at some of the concerns that patients have about how it's affecting not just them, but their families. And I'm just kind of curious, if anybody who has migraine headaches or a close relative who does, would you raise your hand? Keep your hand raised if you or that person has tried preventive therapy. Keep your hand raised if they've tried preventive therapy and it's really not worked well. I'm not surprised. I'm like many of you, and I know this isn't a random sample of Americans, but we all have some connection to people with migraine who are living with it, who've lived with it for a long time. And we know how serious it can affect people and how difficult it can be to try to juggle existing insurance structures, et cetera, to get treatment. And again, the opportunity to think about an innovative new treatment is part of why we're here today. The other reason is because often when there is innovation, especially with new mechanisms of action, it raises a lot of questions about what's the appropriate use of this in clinical practice? How much can we afford? For whom? How do we kind of put this all together? And one quote I brought is from an article that was reflecting on this, and it said an estimated 3.5 million patients have already tried a migraine preventive therapy here in the United States, and approximately 80% stopped that therapy within a year. And that's according to the calculations of one of the manufacturers. So 80% of 3.5 million is 2.8 million Americans. That's a lot of people who are trying preventive medication and are stopping them, probably because it's not working. So all of this also, concerns about access arise because patients can have difficulty accessing new drugs. The rules to get them can be very complicated. Sometimes it's hard for clinicians and patients to figure out what the rules of the road are. And so we've always thought that it really would help if we can have a public discussion based on an objective evaluation of the existing evidence and to try to pull together the threads of what we know today. We know that the evidence base is young because these drugs are just coming into practice. But what can we know today, since they are being asked for, they are being prescribed? What do we know today about their effectiveness, for which patients they offer the best promise? What can we know today about their long-term cost effectiveness and their potential budget impact? And how can we weave that together in a public discussion to help create a pathway to make sure that we get real, true, sustained access to high-value care for patients. So, as the forum for this, we are happy to convene the California Technology Assessment Forum. You've met their members today. I need to tell you a little bit about ICER, which is the group that creates the academic kind of product that is discussed here today. So ICER is an independent, not-for-profit group, and here's our complete funding stream. As you'll see, the big red chunk, 78%, is from nonprofit foundations, and that's the money that goes to these reports and meetings. And the chief foundations in that group are the Laura and John Arnold Foundation, the California Healthcare Foundation, and the Blue Shield of California Foundation. And we get roughly the same amount from healthcare manufacturers, drug makers, and biotech companies, and payers and PBMs, but that's for a separate policy summit program where we bring their leaders together to talk about evidence policy, and a small amount left over from government contracts. The report itself today, that many of you have looked at and that will be discussed in detail, started about 8 months ago. It starts with a scoping phase, and that's when we try to learn what we don't know by talking to patients and patient groups, to clinical experts, certainly to the manufacturers in this area, and other stakeholders as well. Now, we were lucky in this case because we had recently launched a new approach to being able to take information, confidential information from the drug manufacturers that could improve our understanding about the effectiveness and value of these drugs, but which elements of still need to remain confidential. So you'll see reference to some of this information throughout the day, but it has been submitted by manufacturers and it will ultimately be published, and there's a timeline for that so that we make sure that the evidence eventually, we always try to get it out as quickly as possible, but where necessary, we are willing to take this evidence in confidence as long as we can feel confident that it will be available to the public within at least 18 months. So, along with that, we do an internal review of the existing evidence by the ICER staff, and we often work with outstanding external cost-effectiveness experts. In this case, they were at the University of Illinois, Chicago, who led the cost-effectiveness modeling. Through several different phases of public comment and revision, we were also aided by expert report reviewers, including those 4 individuals that you see listed up there, one of whom is at the table already. None of them should be in any way considered responsible for anything in the report. They do not necessarily agree with it, but they gave us feedback, and we were very glad to get it in many different ways. So I'd like to kind of close by saying, how is the report itself structured to support a discussion around effectiveness and value? And to that, I just want to show a brief schematic. And it starts really, again, with this overarching goal. We hope that our work in this public discussion can lead to efforts to really achieve what we don't have yet in the United States, which is a health system that can guarantee sustainable access to high-value care for all patients. To get there, we think we need to think altogether about 2 things. One is the long-term value for money, and I'll say more about what's enclosed in that broad concept, as well as the short-term affordability, because the 2 can sometimes be in tension. For the long-term value for money, however, it begins with a clear-eyed look at the comparative clinical effectiveness of new treatments compared to what we can currently do. It includes the incremental cost effectiveness looked at over the very long term, in which we try to wrap up all the clinical and other benefits for patients, as well as the cost throughout the healthcare system, not just on drugs. And then we also want to talk about things that might slip through, that might exist outside the evidence even, but that could be considered potential other benefits of new treatments or different care options, as well as some contextual issues around the severity of the condition and other things that you'll see when we get to the votes. So when we do come to the voting, there will be explicit discussion about these elements as a set of factors that need to be considered in a vote on long-term, or judgment on long-term value for money. There's not going to be a vote on short-term affordability, but we will talk about potential budget impact. Again, sometimes, especially for conditions like migraine, where there are millions of affected patients, there's an issue about how we manage long-term value with the reality of what it's going to do to short-term budgets, and what that means and how we think about how insurers, manufacturers, doctors can help manage both. So with that as an introduction, just again a brief statement of how today's meeting will be run, the agenda. So we'll start following my opening with presentation of the evidence from Alexandra Ellis of the ICER staff and Suri Walton from the University of Illinois Chicago. Then there will be a phase for manufacturer comment and discussion with the CTAF panel. Then public comments and discussion, followed by lunch for the CTAF panel and the policy roundtable. Lunch will be just across the way. For the public, I'm sorry we couldn't make lunch available for everybody, but there will be, I'm sure there are options available. Oh, we are. You get a free lunch. There you go. Aren't you glad you came? In this case, there is such thing as a free lunch. We won't even take your email address and try to contact you later, I promise. So, following that refreshment, we will come back for the final phase of the deliberation and voting on clinical effectiveness and value, followed by a short break, and then the policy roundtable, where joining the patient experts and the clinical experts, we will have representatives from insurers and from the manufacturers, again, to wrestle with how we do this going forward. What do we take from our review of the evidence today? How do we plot a strategy forward? How do we create clinically sensitive coverage guidelines? How do we talk about pricing, cost, future research, the things that we need to think about going forward? We'll have final reflections from the policy roundtable and the CTAF, and promise to get you out by 4 o'clock. So thank you again for being here today. And with that, I will hand it back over to our chair, who can introduce the beginning of the evidence review presentation.
Thank you. So we would like to begin with Dr. Alexandra G. Ellis, who will begin the evidence presentation.
Thank you. I'd first like to acknowledge the contributions of my collaborators, Aoife and Catherine, and just note that we don't have any conflicts of interest for this report. So migraine is a debilitating and recurrent headache disorder, and it's also fairly common. It affects approximately 20% of women and 10% of men. Patients with migraine may experience moderate to severe headache pain, as well as other symptoms. Because the frequency and intensity and duration of these symptoms can vary between individuals and may fluctuate over time, the burden of migraine may be more severe for some patients than for others. So some patients may have a mild intermittent problem that can be treated with lifestyle changes or oral analgesics. Other patients, migraine can be severely debilitating. In addition, when patients experience migraines, if they're unable to obtain relief from their pain, they may seek care in an emergency setting. And of course, this is associated with substantial costs. Patients with migraine may be diagnosed as having chronic migraine. So this is for patients who experience 15 or more headache days per month, with migraine features present on at least 8 of those days. Patients with migraine who have not been classified as chronic migraine may be termed episodic migraine, but just note that this is not a clinical diagnosis. Among patients with migraine, approximately 10% have chronic migraine and 90% have episodic migraine. We heard extensively from individual patients how living with migraine can be very difficult and debilitating. So for example, some patients reported feeling frustrated when they were trying to communicate their pain and symptoms to others. Other patients felt depressed and even experienced suicidal thoughts. We also heard several comments from patients about how migraine can strain their relationships with family, friends, and coworkers. And this can be for a range of reasons. For example, some patients may not want to plan or commit to plans because of the uncertainty about when the next attack would occur. Other patients felt that their migraine pain was not taken seriously by others. Treatments for migraine first include some behavioral changes as well as some non-pharmacologic options. In addition, patients can take acute treatments. So these treatments would be taken at the onset of migraine symptoms, and that includes options including NSAIDs, triptans, and opioids, among others. Just a quick side note about opioids. Despite recommendations against using opioids as a first-line acute treatment, many patients with migraine are, in fact, prescribed opioids. So because of the concern with the opioid epidemic and its association, there is concern about this in the migraine population. In addition to acute treatments, some patients may be eligible to receive preventive therapies. So preventive therapies would be given for a short period of time or a longer period of time, and the goal would be to reduce the frequency or intensity of the migraines. Many preventive treatment options for migraine are available in a generic form and are taken orally. So that includes some options for within antidepressants, anti-seizure medications, as well as beta blockers. In addition, onabotulinum toxin A, or Botox, is indicated for the chronic migraine population. So there are no strict guidelines on who is eligible to receive preventive therapy, but in general, patients who have 4 or more headache days per month are considered candidates. And when a patient starts a preventive therapy, they're recommended to take it for a minimum of 2 to 6 months. And the reason for that is that there may be a delayed onset of efficacy. So it can take some time for patients to be able to find the treatment that works best for them. Patients also frequently discontinue or switch therapies due to lack of efficacy, but also and also because of tolerability concerns. So some common tolerability issues include difficulty with concentration, memory, or speaking clearly. Interventions have also associated with weight gain or loss. And we did hear from patients how frustrating and challenging it can be to find the right therapy for them. So these guess and test procedures can take many years before finding an effective treatment, and it's very frustrating to keep trying different things. When they do find that treatment that works, it may often stop working after a set period of time. And in addition, those side effects that I mentioned can be more debilitating or as debilitating as the migraine itself. So of course, there is a need for more effective and tolerable medications for migraine patients. There are many agents in development right now in a new class of therapies. So these are the calcin gene-related peptide, or CGRP inhibitors. And the CGRP pathway is important in pain modulation. The first of these CGRP inhibitors was approved by the FDA last May. And this is erenumab. And erenumab works by binding to the CGRP receptor. 2 additional therapies, fremonizumab and galcanezumab, work by blocking the CGRP molecule itself. And the FDA is expected to make a decision about these therapies by the end of this year. So here we've sought to take a look at the clinical evidence that's currently available on these therapies. Our scope of the review included adults with chronic or episodic migraine who were eligible for preventive treatments. And so we looked at chronic and episodic migraine separately. We also looked at the subgroup of patients for whom existing preventive therapies have failed. The interventions of interest were the 3 CGRP inhibitors, erenumab, fremonizumab, and galcanezumab. And note that these interventions are self-administered and typically with a 1-month frequency, although 1 dose of fremonizumab has been studied in a quarterly frequency. For comparators, we included 3 oral preventives, amitriptyline, propranolol, and topiramate. We also include Botox in the chronic migraine population. And for both populations, we included placebo or no active preventive therapy as a comparator. In terms of outcomes, we included all of those listed here. I just want to also draw your attention to our main outcome of interest, which was monthly migraine days. So for the evidence base in chronic migraine, we identified 3 trials of the CGRP inhibitors. So 1 trial in erenumab and 2 trials in fremonizumab, and no trials in galcanezumab. We also have 13 trials of Botox or topiramate, and of these trials, 11 were included in one or more of our efficacy analyses. We did not identify any trials of amitriptyline or propranolol that met our inclusion criteria. So here's a summary of the baseline characteristics of the patients included in the CGRP inhibitor trials. So as you can see, the average age across the trials was very similar, approximately 40 years old. And the average number of migraine days per month at baseline was also similar. Just note here that in the arenumab trial, patients were not allowed to continue using their preventive therapies, whereas patients in both of the fremanezumab trials could continue using preventive therapies. These trials had a 4-week baseline period, and they were a 12-week randomization phase. So here is an illustration of the available network of evidence that we had for the outcome of monthly migraine days. So here the nodes represent the individual treatments that we looked at, and they're color-coded, so green for the CGRP inhibitors, orange for Botox, and blue for the oral preventive therapies, and black for placebo. The presence of a line indicates a study has compared those two interventions head-to-head, and the thickness of the lines is proportionate to the number of studies. So we had 2 trials for Botox versus placebo, and for fremanezumab monthly dosing versus placebo, and 1 trial for the other connections. So we conducted a network meta-analysis, and the main results from the network meta-analysis for monthly migraine days are in the first column here. And so this is expressed in terms of a difference in the change from baseline of monthly migraine days for each intervention versus placebo. And so a negative value indicates a larger reduction with the active therapy compared with placebo. So across the CGRP inhibitors, we saw between about 1.3 and 2.4 fewer migraine days per month compared with placebo. And these results were not statistically significant compared to Botox or topiramate. In the second column, you'll see the results when we anchor with a placebo response of 4 fewer days per month. And this is just for illustrative purposes, but we want you to focus on the first column as the main results. I also just want to comment that we did have subgroup data available that was submitted in confidence for this outcome. So we're not presenting that data here, but it is available to the panel members in your packets. In terms of other efficacy outcomes, we were not able to do a quantitative synthesis of the proportion of people who had a 50% or more reduction in monthly migraine days, and that's because the way that the trials reported this outcome varied. So some trials used 50% response in terms of migraine days, others used it in terms of headache days or moderate to severe headache days. In terms of acute medication use, we saw approximately 2 fewer days using acute medications per month by the end of the trials. And quality of life measures were not frequently reported across the trials, but where they were reported, we saw larger improvements with the active therapies compared with placebo. But these may not be clinically meaningful differences between groups. For the evidence base for episodic migraine, in our reports and in our analyses, we've included 6 trials of CGRP inhibitors. However, in the past 2 weeks, there were 2 additional trials published on galcanezumab. So currently, they're not included in our report or our analyses, but I will make a couple of comments on them when we get to the results. We also have 24 trials of oral preventive therapies, and of these, about 16 were included in 1 or more of our efficacy analyses. Again, here is a summary of the baseline patient characteristics across the CGRP inhibitor trials. And just note that the last 2 trials, Evolve 1 and 2, are the 2 new galcanezumab trials. So these are not included in our analyses at this time, but just to note that they did have similar baseline characteristics as we saw with the other CGRP inhibitor trials. So overall, again, the average age at baseline was similar, about 40 years. And the average number of migraine days per month was also similar across the trials, with the exception of 1 trial in fremanezumab, which looked at high-frequency episodic migraine. So the baseline number of migraine days was a bit higher for this trial than the others. Again, note that Most of the trials did not allow patients to continue using their existing therapies, with the exception of the fremanezumab trials. So here is an analogous figure of the network of evidence for episodic migraine in terms of the outcome monthly migraine days. You'll note here that the CGRP inhibitor trials were all compared versus placebo, and we do have some head-to-head evidence between the oral preventive therapies. The results from the analyses, again, are expressed in terms of a difference in change from baseline for each intervention versus placebo. And as a reminder, a negative value indicates a larger reduction. Here we saw about 1.2 to almost 2 fewer monthly migraine days with the CGRP inhibitors compared with placebo. And these results, again, were not statistically significant versus the oral preventive therapies. I also want to comment that the subgroup data for the patients from whom existing therapies have failed is also provided in confidence and available to the panel members in your packets. In terms of other efficacy outcomes, we saw approximately a 2 times higher odds of having a 50% reduction in monthly migraine days with the CGRP inhibitors compared with placebo. So there may be some evidence to suggest that there is a subgroup of population that respond very well to these drugs. The results for acute medication use and quality of life measures were similar to what we saw in the chronic migraine population. In terms of tolerability and harms, overall, the CGRPs were well tolerated with infrequent and non-serious harms reported. So we did not find a difference in the meta-analyzed odds of discontinuations or serious adverse events. In the CGRP inhibitor trials, the most commonly reported adverse events related to injection site reactions or pain. In the oral preventive therapies, common adverse events included fatigue, memory loss, and difficulty concentrating, which were not frequently reported in the CGRP inhibitor trials. So in terms of controversies and uncertainties, first, that these trials were short-term, so between 12 and 24 weeks in duration. So there is some uncertainty in terms of the durability of any effects from prolonged use. And that includes durability of continuing to use the treatments and also any lingering effects that may occur once the patient stops taking the intervention. These are the first agents in the CGRP inhibitor class, so there is concerns about the longer-term effects of the continuous blocking of CGRP or its receptor. So CGRP is throughout the body and it has different functions. And so one concern is in particular because CGRP has a protective role during ischemic events. There may be a concern that patients who are at higher risk for cardiovascular events may not be well suited to take these interventions. There's also concern about the generalizability of these results. So the patients that might use these interventions in clinical practice may be those that have failed many interventions in the past or who have comorbidities. And these patients were not studied in the clinical trials. So just to summarize, we did see some clinical benefit with the CGRP inhibitors and few harms. But these trials were short-term, so we have limited certainty about the longer-term effects of these interventions. However, there are longer-term studies that are ongoing. Some of these trials did have open-label extensions. So we overall rated the evidence as insufficient for most comparators and populations. And the rationale for that was we did see clinical benefits, but these trials were short-term, and there's considerable uncertainty about the longer-term effects of these interventions. And this is particularly relevant because patients will be taking these drugs for a longer period of time, particularly patients with chronic migraine. The exception was that for patients who have more severe disease or who may not be able to take or who may not have other options available to them, we rated the evidence slightly higher. And that was because we thought that the benefits would perhaps outweigh the potential risks among these populations. So for episodic migraine for whom oral preventive therapies have failed, we rated the evidence as promising but inconclusive. And the same population in chronic migraine, we rated the evidence as comparable or better. In addition to the clinical evidence, there is other benefits and contextual considerations. Again, these are administered monthly or quarterly, which may reduce the burden of migraine treatments. But these are subcutaneous injections, so that may add some complexity to the treatment. If these interventions are both tolerable and effective, patients may be less likely to discontinue their treatment. And it may also have other effects in terms of an increased ability to work and improve overall productivity. Again, these are interventions that have a novel mechanism of action, and they may have an earlier onset than existing preventive therapies. So I'd just like to end on a couple of comments that we received from the public. The first was that the review should evaluate the CGRP inhibitors only in their likely treatment paradigm. So that would be among patients for whom preventive therapies have failed. And so during our scoping calls and conversation with patients and clinicians, we heard that there's an interest in the wider migraine population. So we took the approach of looking at both the wider migraine population as well as this subgroup for whom existing therapies have failed. Another comment was that phase 2 and phase 3 studies should not be assessed together. So here we wanted to look at the totality of the evidence base, so that includes phase 2 and phase 3 studies. We included any study in our quantitative synthesis if it was similar in terms of populations, outcomes, and interventions. And just to note that due to smaller sample sizes or larger variances, which is more common in the phase 2 trials, in the quantitative synthesis, these trials would be given less weight. And finally, a comment that galcanezumab should not be included in the review at this time because it was further behind in its development. But we argue that stakeholders are beginning to make decisions about arenemab and thinking about the other CGRP inhibitors as well. But we do know that there was a limited amount of data at this time. So galcanezumab was included in our clinical review, but it's not included in our economic evaluation. So I'll stop there.
Are there any questions for Dr. Ellis, panelists? Thank you.
Thanks.
So I'd like to move on to our next presentation of the evidence with Dr. Suri Walton from University of Illinois, Chicago. Dr. Walton.
Hi, good morning, everybody. So I'm going to start by just acknowledging my colleague Todd Lee at UIC, who was a co-leader on this project. Also, some kind of key team input came from Danny Kwok, who was an RA for us there. Also, Varun, Kumar, and Rick Chapman from ICER, and really the whole ICER team had useful input for this. And none of us have any conflicts of interest relevant to this report. So the primary objective of the economic model here was, in the base case especially, was to estimate the cost effectiveness of arenemab and fremonizumab compared to no preventive treatment for patients with chronic and episodic migraines for whom other preventive migraine medications had failed. So that was the target group here. And we have separate models for chronic and separate inputs into chronic and episodic. So I'll get into the methods. So this was a semi-Markov model with time-dependent efficacy and mortality rates, slight changes in the efficacy across months in the first few months, and mortality rates, very slight changes in the second year versus the first year. The setting was the United States. We took a health sector perspective. We used a time horizon of 2 years, and we based that on because of high discontinuation rates generally seen, and mainly because of the literature, past models that use that time horizon. If we vary the time horizon in our model, it really doesn't have a big impact, but we view this as a 2-year model. We have a 3% discount rate per year, a cycle length of 1 month, and the primary outcomes are costs, quality-adjusted life years. We also have migraine days reduced, and the primary outcome is cost per quality-adjusted life year gained. Here's just some summary demographics of sort of the prevalent population of chronic and episodic patients that we thought would be the best fit. The model, which primarily impacts the mortality rates. So you can see about 40 years old, mostly female, and you can also see here the mean migraine days per month in chronic and episodic is sort of a baseline. These are the drug regimens that fed into the efficacy values. Arenumab recently got approved, by the FDA at 70 and 140. And fremonizumab has a couple of different dosing regimens, but we picked the ones that had the highest efficacy rates from the trials. So that's why we chose these. Here is just kind of an overview of the model, relatively simple model. In the treatment arm, you start on a CGRP inhibitor. You can discontinue. When you discontinue, you go to no preventive treatment. And again, this is to reflect patients that have already tried and failed therapy. So the view here is if they fail on CGRPs, they just go to no preventive treatment. And the other comparator arm, you just have no preventive treatment. And then there's a small potential for death on both sides of the model. So specifically, these model transitions, the discontinuation rates come from the clinical trials, from an NMA of clinical trials, and the mortality rates come from CDC, age and gender-adjusted CDC rates. So here are the key assumptions. First, that the CGRP inhibitors have no direct effect on mortality, outcomes, or cost of treating underlying conditions other than migraines. So the treatment effect is all coming through the impact on migraines. The effect of migraine days on utilities is based on disutility weights for mild, moderate, and severe migraine days from the literature, and I'm going to show you those later. Changes in the distribution of mild, moderate, and severe migraine days. So a treatment effect can reduce migraine days. A treatment effect can also reduce the frequency distribution of severe relative to moderate and mild. And we had some available data come in from fremonizumab to include that sort of treatment effect. So we did that, and we also took that same effect essentially and gave it to arenumab. We didn't have data for aranumab at that level of detail. Reduction in migraine days resulted in proportional reductions in other forms of healthcare utilization, such as hospitalizations, ED visits, and PCP visits. So our best way to estimate this was to tie those resources uses to number of migraine days and then proportionally reduce them as part of the treatment effect in terms of costs. The AEs that we saw in the clinical trials were relatively mild, but worth noting. So we put those in the model and we assigned them a cost of a primary care physician office visit, a modest cost there, and an assumed mild disutility of 0.05. So just to try to kind of include the idea of adverse events in the model. And the cost of CGRPs were based on aranumab's initial launch price, which we discounted by 27%, and then we rounded it, and we applied that to both drugs. So here's some of description of the inputs. First one here is discontinuation rates, and seen in chronic and episodic. Again, these came from an NMA, about 3% per month in the chronic for aranumab and 6% in fremonizumab, and a little bit higher in the episodic model. Here's just again the costs, which came out to be $5,000 after we took the price and discounted it and rounded it. We also included a small administration fee just in the first month for the drugs. So one key model input here is the use of acute drugs. And here you can see the baseline rates that we took from the literature projected for like a prevalent population. We have a cost per day for acute medications that came from the literature. And then we have reductions, separate reductions of the days of use that came from an NMA. That kind of information was available from the clinical trials. So here you can see it for acute versus, in chronic versus episodic. Again, in addition to the reduction in acute medication use, there's also some reduction in other healthcare resource use that's proportional to the migraine days. And this just shows the cost per month associated with these visits at baseline to give you a sense of how much these contribute to costs. And down below, there's some more detail. These are costly events, but they're relatively rare. So in the model, they're not a large monthly cost, but worth considering. Here are the adverse event rates. again, seen in the trials, and the costs that are associated with them based on the assigned cost that we use of a physician office visit. Again, relatively small. So here are the utilities that are a really key input into the model. We got the distribution of severity of migraine days from the literature, best source we could find. It's worth noting that this utility associated with severe migraine day of 0.44 is actually a very severe condition. If you compare it with utility scores, it sort of lines up with very severe heart failure. It's below that for blindness. It's near that for a acute psychosis. So it has some face validity in terms of just comparing this with similar numbers from very severe conditions. We got this from the literature. So here are the results. In the chronic model for Arenumab, we ended up with $90,000 per quality-adjusted life year. And these are rounded to the 10,000 to kind of protect some of the redacted data that we used. And for Imnizumab, it was $120,000. And in the in the episodic patient population, ended up being $150,000 or very near that as an average value for both. So we conducted a number of sensitivity analyses. These show one-way sensitivity analyses. And I'm just going to show this for Arenumab for episodic. It was very similar across the drugs and across the models in terms of what inputs were important. So first of all, the migraine day reduction itself was a key, very important input, not surprising. Drug costs, migraine day utility, and migraine-free day utility, also relatively important variables. And then the impact of variation in the rest of the variables was lower from there. This summarizes a probabilistic sensitivity analysis. You kind of take variation and a lot of possible variation in the inputs and run a bunch of simulations. And this tells you of, say, 10,000 simulations, what percent were below, of the ICERs from those simulations were below a particular value. So at 100,000, you can see that only 23% for Fremanizumab was below that, although 66.8% were below 100,000 for the Arenumab. If you go to 150,000, you see that the majority of times the simulation had favorable incremental cost utility ratios at 150,000, meaning they were below 150,000. So it's very likely from the data, at least from the model, that the incremental ratio would be below 150,000. It's a little different in the episodic migraine. We had that the sort of mean value was 150,000, but if you take potential variation again in the inputs, it turns out that the majority of time the incremental cost ratios are a little bit above 150,000 in episodic. We also ran some scenario analyses, and we ran a variety, but we felt like these were the two to highlight. So one is taking patients and comparing CGRPs to sort of other available treatments that are currently on the market. And we used a mix of treatments and NMA results, and we found that relative to that, we have very high incremental cost utility ratios of choosing CGRPs in a general patient population versus the currently available treatments. On the other end of the spectrum, if we include the impact of reduced migraine days on productivity, we took some estimates from the literature there, we get much more favorable cost utility ratios. So it's $50,000 in the Arenumab and $80,000 in the Fremanizumab, lower for both. And even in the episodic, where, remember, we were at 150,000, if we include the productivity effects, we're down to 110,000. So here are the limitations, our two key ones. The models are inherently based on clinical trial data over relatively short time periods that may not reflect longer time horizons or real-world use. And the model applies to an average patient with chronic or episodic migraine for whom other preventive treatment options have failed but may not reflect particular subpopulations. These are kind of generally true of models. So here are some public comments relative to the model. First is that a societal perspective should be employed, as CGRPs will have productivity effects. So ICER focuses on a health sector perspective as its base case model. We did do a scenario with productivity effects, and you can see it does have an important impact and lowers the incremental cost utility ratios. CGRPs will help with depression as well as migraine. We actually ran a scenario taking some available data on that, and there is some evidence suggesting that, but it had a relatively small effect on the incremental cost utility ratio, but there does seem to be some data that this is true. CGRPs will reduce issues with opioid addiction. This may be true. This is a thing that's hard to get good data on a treatment effect on the impact on future opioid addiction, but it's worth mentioning. We didn't include it because we didn't have good enough evidence to try to model that. Non-responders will discontinue, leaving only responders, such that long-run cost effectiveness of CGRPs will improve over time. We actually don't see this in the data. So if this were true, and there are high discontinuation rates, you'd expect to see the efficacy of the remaining patients really increase over time, and there just isn't data that shows that. So we've also heard from clinicians that responders may discontinue. So that's maybe an open question, but we don't see evidence for that. And CGRPs may impact schooling achievement and impact future employment status, including job promotions. This I just put out there because I think that this might be possible, and maybe for particular patient populations, and it's kind of worth thinking about. This is something that it's very hard to get evidence on this, especially for kind of the general patient population. And so we didn't have a way to model that, but I think it is worth thinking about and might be true for particular subpopulations, but hard to establish that empirically. So in summary, arenumab and fremonizumab are projected to reduce migraine days and improve patient health. At currently expected discounted prices, arenumab and fremonizumab are projected to have incremental cost effectiveness ratios essentially below 150,000 in chronic migraine, for whom, and this is in patients for whom other preventive therapy has failed. CGRPs are expected to have cost effectiveness ratios around, but likely above 150,000 when used in patients for whom prior treatment therapy has failed in episodic. If we include productivity effects in CGRPs, we get more favorable incremental cost effectiveness ratios. However, CGRPs compared to currently available therapies are projected to have incremental cost effectiveness ratios that are well above current thresholds. I believe that's it.
Thank you.
Yeah.
Are there any questions from the panelists or our experts? Any comments on the evidence presented?
Yep.
Thanks for that presentation. A lot of effort clearly went into those analyses. Could you talk a little bit more about the source for the utility values that you included, and how that was done and where it came from? And also, one other question, but maybe I'll ask that after the utility question.
I'm just going to go back to that slide. The utility scores came from a study by Zhu, 2011. So what's the exact question there?
How did they assess the utilities among what kind of people,
these are,
how many people?
I'm not going to know the exact specifics on this, unfortunately. But this was a general study of utility scores associated with description of this health state of having a severe migraine day, similar to how other utilities are done. What I don't recall is whether this was a time trade-off or a standard gamble utility. I don't have that level of detail.
Do you know how many people they assessed? Were they migraine sufferers, people reading descriptions of migraines?
Again, I apologize. I'm going to have to look that up, and I can.
We'll try to look it up.
Yeah, we can look that up. Again, these utility scores, to me, have pretty good face validity in terms of being compared to other utility scores and other chronic conditions, which we looked at. So 0.44 is a very low utility score.
Yes, I know.
Yeah.
One of the reasons I'm asking.
Yeah.
And then second question is about the costs of episodic migraine therapy. You said came from the literature. Can you talk a little more about
the
that?
cost of episodic?
Like treatments, acute treatments for migraine was $24 a day, but I'm curious.
Yeah, that came again from a paper from Masali. So that I believe was based on patient survey, but it just took a mix of treatments that were commonly used by patients, and then we took a market price for that, or they had taken a market price for that and assigned it to that mix and gotten a cost per day.
I guess my question is, when you did the pricing on the new drugs of interest in the analysis, you applied a discount rate to that, and I'm wondering if there was any, like discounting or other assessment of the $24 a day price, because it seems a bit high.
I think that, again, we took this from the other study.
Mm-hmm.
I think they were trying to have a realistic cost. Drug prices are something that are hard to get exact data
Yep.
on. So I mean, it's a valid point. I would say that the impact of this number on the model is very small. So
Okay.
if you took a lower value of this or a higher value of this, it has a relatively small impact.
Okay, thanks.
The
Alex?
utility score
sorry.
does have a big impact, so that's
Yeah.
important.
Thank you for the present. Oh, sorry, I have a question.
I have another question, sorry.
Thank you for the presentation. I just want to clarify, when we're talking about patients who have failed prior preventive therapies, we're talking about patients who have failed 1, 2, or 3 preventive therapies, because we have no data on patients who have failed 4 or more preventive therapies because they were excluded from trials.
That's correct. So that we only have the data available in the clinical trials, and it's a point that was brought up in the first presentation, but you could add it as a limitation here. So we got data conditional on failing at least 1 treatment as our best guess at this number. But
right, at least 1, but no more than 3.
From whatever was in the trial, and that was generally what was in the trial.
Say.
The one question that I had was, in your sensitivity analysis, did you take a look at if the efficacy of the treatments were lower than in real life than seen in the trials? And this is from many other disease processes where we know that patients who enroll in trials are more compliant, different in some way, and that in the real world, the efficacy seen, and this is seen mostly in kind of the other drugs where we have a lot more experience, like statins, the actual efficacy seen in the real world is actually substantially lower, and actually lower by a predictable amount than what's seen in the original research trials.
So here, the top bar in this one-way sensitivity analysis shows you the impact on the incremental cost effectiveness ratio if you vary the efficacy, and it has a very big impact. So if there are differences in efficacy in the real world, they will have very big impacts on this. So it's a good point. We did do it.
Can you tell me the range of efficacy that you varied in the sensitivity analysis in the bars that we see?
I believe this is taken from the standard deviations from the NMA, and so it's applying a confidence interval to that. And there's a little, there's a big impact from it. Yeah. So I can't get into the redacted data, but having a difference of 1 migraine day, for example, is a very large difference in the incremental cost effectiveness ratio.
Hi, this is David Rand. I just wanted to go over from the Zhu paper what it says in the methods, which is 330 20 to 65-year-old adults in good physical health who had 1 to 6 moderate to severe migraine attacks per month in the 2 months prior to the visit. This was done in the setting of a trial of acute migraine treatment, so they were examining what their utilities were using EQ5D during the acute attack, then they were treated and better, and comparing that to how they were after the treatment.
Thank you. I actually have a question that I would actually like the experts to comment on as well. This issue of discontinuation was quite interesting. It seems as if patients discontinue for a variety of reasons, some because the drug is not working, some because of side effects, and we've heard recently about these patients who actually respond and then discontinue. And are they discontinuing because they have some sort of perceived persistent benefit? And I'd like to know what role that plays in clinical practice. How often is that phenomena observed?
So it's really hard to know the exact numbers because no one's actually followed in that way. And so it really comes from personal experience. So I think if I look at my numbers of new patients and the numbers who come back, only a small number come back for that second visit. When I first started working, I had free time. So if a patient didn't come back, I'd call them up and I'd say, why aren't you coming back? And they would tell me, well, I'm better. So why do I don't need to come back? And then over the years, I've now worked at Kaiser for nearly 15 years. And I will see patients back like a year later, and just like this last week, someone came back 10 years later. And they came back 10 years later because they used their preventative for a while, and the headache went away, so they stopped it, and the headache recently came back, and so they wanted treatment. But it's hard because, I don't have numbers for that. Certainly, some patients will say, well, I've tried so many, I'll see someone back and they'll say, well, I tried so many things, I stopped it because it didn't work, and I figured, why should I come back? So I'm coming back for something that's new. But in general, the more frequent someone has, the more frequent and disabling a migraine is, the more likely they will come back if they've stopped a preventative because they want to try something else. But there's no numbers that can be captured with that. But a good number of patients do, and I keep my patient lists, and it's now in the computer. So a good number of patients don't come back because they got better, and they stop it because they figure, well, I'm better. Do I really need to continue? And then some will try and they'll stop it, and then on their own they'll say, oh, the headache came back, so they'll restart the medication. But unlike, we have no numbers for that we could find in any case. Because in general, patients don't want to continue to take a medication if there isn't a benefit, and on their own, they will stop the medication. And when we counsel them, we tell them about, is this something you can stop, or you have to taper, or to sort of give them that sense. And then some patients, when they come back, they can discontinue. They actually come back and they're doing really well, and they're rarely having a migraine, and they're back 6 to 9 months, and they say, oh, can I stop? Or I will ask them, do you want to stop? And again, we don't have any numbers about, when it's physician-directed about stopping the preventative, how many come back or how many do.
And is it generally the expectation that when you start someone on a preventive that they will continue on it, or is there an expectation that at certain points you try to wean off and see how they do?
So the expectation when I tell patients is that if this really works for you, that anywhere from 6 to 12 months, depending on how they do, that we can wean off the medication and see how they do. Some patients who've really had tons of migraines don't want to wean off ever. They want to stay on, and that's fine. Some patients really want to wean off, and they drive it a little bit more. But I tell patients that this is not lifelong. And it's not a lifelong treatment because for many people with migraine, so migraine is a lifelong disorder whose natural history is characterized by fluctuations. You'll have periods when you have more migraine, you'll have periods when you have less migraine. Everyone's triggers are different. I mean, for some people, until this thing gets over in their life, they're just going to have lots of headaches. For some people, you can never find that treatment. The best data I found was a recent study from electronic diaries that people use to record their migraines that found that people who have chronic migraine, just natural history without any treatment, sort of fluctuate between the chronic migraine state and the episodic migraine state. It's not looking at anything like disability or anything less. It's just looking at headache days. People with episodic migraine tend not to cross that border into chronic migraine. Natural history other studies tell us if you're in the high frequency role, which you can't actually distinguish with the numbers we have, where you have, you're not quite chronic migraine, that you'll have a tendency to go forward. And so because there's so many factors, triggers that vary per patient, for many patients, you have a lot of migraine, you use a preventative, you get better, you figure out your triggers, you address those triggers, and now you come off. And so, that's why understanding yourself, behavioral migraine management, trigger identification, that's what provides a lifelong management for migraine. For some patients, not all, some patients need lifelong, or not lifelong, but decades of prevention. But people want to come off because they're better. There's also natural history just to migraine frequency based on prevalent studies. So, particularly you see this for women. You have this curve in the 20s and 30s, and post-menopause headache goes down. And that it just does on its own without any treatment forever. So there's never that sense. I'm sorry, this is very long-winded, but there's never that sense that someone's going to be lifelong on treatment for migraine.
Thank you. Thank you. We have time for one more question. I think Jeff's board is up. Oh, I didn't see yours, Kim.
Thank you. I'll make this quick. Thank you very much for the presentation of the economic evidence. I wanted to see if I understood it correctly. When considering the value for money of the CGRP inhibitors as preventative treatments, the answer to the question, are they cost effective, depends on what you're comparing them to. Is that right?
Definitely. So it always depends on what your threshold is for cost effectiveness, right? When we have a different model in chronic and episodic, in the chronic model relative to no treatment, it appears to be below 150,000. In the episodic, it's a little bit above 150,000 relative to no treatment. When you take these and compare them in a general patient population relative to like the prevalent treatment mix, they're very much not cost effective.
Okay, so I just got word from the holder of the clock that we have time for a few more questions. I think, Kim, your board was up?
Yeah, I was, this is probably more for the experts, but I think 17% of patients discontinued because of nasopharyngitis is like the overwhelming side effect. How significant is that? I mean, how do they really present?
So I haven't prescribed, because these are new and I haven't used them yet. I don't know exactly what that means for the patients. It's actually not one of the side effects that's listed on the FDA label, which is just injection site and constipation. So when I saw that, I am wondering, I think I had a few patients who were in the trial, and so I would ask them, do they know what it is? But I'm really not sure. Maybe, I don't know if one of the manufacturer, who's a company representative, might know that.
We'll hear from them in a bit. Andrew, I think that your board was up. Did you want to make a comment or have a question?
I did. I just wanted to
Kevin,
add
sorry.
into what you had been talking about, the issue of discontinuation rates. And some survey data that we've looked at showed among migraine patients that the number one reason they would discontinue treatment was lack of efficacy. And so knowing that that's the case, it is our assessment that one of the flaws of the model or concerns we have about it is that it doesn't show that those who are on the CGRPs and some show that they're not getting a response, we expect that over a certain period of months they would drop off. And so we think that over time in the real world, different from the clinical trials, where I think many people sign up and whether they're seeing benefit or not, they see it through to the end of that clinical trial. It's sort of what they signed up to do. But in the real world, we anticipate people will, after some period of months, determine with their physicians, is this or is this not working for me? And for those who it is not working, we don't expect them to continue the treatment. And I think that over time, that will increase the rate of the efficacy of these medicines that may not have been seen in the trials, but we anticipate that in the real world. So we anticipate that as something that the model didn't accurately capture here.
So we've already talked a lot about this, but this was just a 2-year model, and you could see there's a lot of reasons for discontinuation. And so we felt comfortable about that time horizon for that. In all other treatments, and Botox in particular comes to mind, in longer periods of time, you don't see this increase in efficacy across time related to discontinuation. That could be true in the CGRPs, But there isn't any reason to expect that to be true given the data that's there.
Mike.
I have two questions. The first is to use a metric that you haven't been using, and this is for the clinical experts. If you use the conventional wisdom around response rate of this group of drugs is around 20%, folks have said. You can correct me if that's wrong, but this is what I picked up around Westwood at any rate. It raises the issue, if you brought a patient in during an attack and measured the peptide, would you be able to more focus the use of the drug, use it in a more personalized way? Because clearly migraine is not one disease, it's multifactorial, and maybe a number of mechanisms create this constellation of symptoms. So is there any practicality to actually bringing a patient in and measuring the peptide to see if the drug should be used or not?
So if I remember correctly, the changes in CGRP are seen across all migraine patients. And so I don't think it is the actual, I don't think that will help. And also CGRP is a transmitter in all primary nociceptive sensory, the nociceptive sensory afferents. And so it's not just restricted to the head. And it will be interesting in, I don't think anyone's done any studies in other pain conditions, but there, there's never been the sense that blockade of this system. Again, no one studied this, so this is actually an interesting question. Will it have a response to other type of pain? Certainly if you look at the triptans, again, serotonin agonists, they help migraine, they also help cranial pain, but they don't help pain everywhere, even though you have these receptors on primary, are involved in transmission of nociception throughout the neuroaxis. So why are these, I think, there are a lot of mechanisms that have been proposed, but we still don't have a way of picking out what's going to help which person, because you're exactly right, the response rates seem to be in line with the other preventatives, and why one thing helps one patient and it doesn't help another patient is likely reflects its polygenetic pathophysiology that differs in people.
I think it's also hard, though, in folks who have multiple comorbidities that involve pain. So isolating that just to the migraine folks is a bit kind of difficult as well to know if it, if there was, a difference in the CGRP levels. Is it significant, or is it because there is something else going on in that patient, unless that patient purely has no other comorbidities and only migraine?
My second question should be quick. Is there a clinical way of tracking patients who have, let's say, like a partial response? In other words, do these drugs behave this way, or any of the management? In other words, a person still has a headache but can function at work today, and the intervention did in fact do that.
So clinically, we do by using disability scales. So when we talk to patients, my practice is headache focused, so all of my patients get a disability scale. So where it looks at how many days with migraine and how much disability that they've had. And so there are ways to do this. It's, as was emphasized in the excellent report, this is not uniformly tracked. In the more recent studies, you have a little bit more data, but you can look at that. And that's one of the, when we talk to a patient about changing, or because sometimes patients are happy and I'm not happy, because I look at their disability stuff and say, hey, that we use that as a marker for treatment response. And I did want to echo what Kevin said, because he's absolutely right. Patients stop when it's not effective, but I wouldn't expect anyone to use something for more than like 3 months. If it's not going to, sort of 2-3 months, if it's not effective, why use it more? Because we can go to something else. It might be a little effective, you might need to do something else if you're at the maximum tolerated dose. But, I'm not going to use something for 6 months to a year and then tell a patient, that's too much time. It's too many headaches, too much, disability. It really is disability.
So I think we're closing.
Sorry, I just wanted to circle back to the issue of whether in the real world with longer term use you'd see discontinuation such that efficacy improves. we don't have a ton of data on this, but we do have the open label extension of the arenumab trial, where the decrease in migraine days really looks very similar to what was seen during the randomized phase. So I think that supports your point that we're not seeing that so much. It doesn't mean it's not ever happening, but at least we're not finding the data to support this idea that as people are using these over time, the efficacy among the continued users is going way up. I'm not sure what to make of that.
I agree. So if I have a patient has been on years on a preventative, I don't get the sense that later on it's going to be much better. You know, typically if they stay on it for years, they're sort of happy with where they're at and they don't want to try anything else. And so the best stories are people with chronic migraine who had really, really, really bad migraine. Now they still have headache every single day, but they have, 4 migraines a month that are easily treated, and that's what they tend to stay until you put on natural history with age. So the one thing that will lead to it will be natural history with age. Clearly, postmenopausal women, clearly there's a decrease in migraine if you look at those curves. That is what will lead to discontinuation. Or if they're stressful life, if there was something that was triggering it, retirement, but that also comes in that same age. So that's when you start to see them get better, and that's when you'll stop. But I don't think it's the medicine working better. I think it's the natural history.
Last question.
Oh, thank you for letting me have the last word. So this is another modeling question that specifically gets to what Dr. Petrovic was talking about in terms of the fluctuating disease course. And I was wondering if the models actually had any sort of accounting for regression to the mean, that most of the time patients are coming to the doctors when things are not going well. This is a naturally fluctuating disease course, which means even without treatment, probably things would have gotten better over time because we are not randomly seeing things. Now, on average, certainly it's not going to be true for everybody, but on average, that's what we would expect across most of these fluctuating diseases. And I was wondering if that was accounted for in the model.
Only in that we have a relatively short time horizon, partly for these considerations. And then I think that potentially explains some of the placebo effect, which is in the comparator arm, which impacts the model.
Okay.
So I will. Well, you think.
I wanted to add that with migraine, it's also common if it's not treated that it may spiral out of control and from episodic become chronic. Is that what you're going to say?
So that was one of the things.
Okay, go ahead.
So there are a couple things I was going to say. So there's a group of people with migraine that don't respond to anything, and they may continue for years. But I do think that that's a very good point, because when people with migraine have had migraine, they go to see a doctor when it's worse. And a lot of the triggers, so you have weather triggers for migraine, you have stressful life event triggers for migraine, and many of those are going to be on a shorter time course than 2 years. So I recently had a patient whose migraine flared because of a death of a close relative. And so patient died, headache got better, she went through the grieving process, there were a couple of things, and now she is better, and she is better she's better 6 to 8 weeks later. Was it my occipital nerve block that made it better? Was the fact that she had a religious experience with her relative that made it better? Was it the natural course of grieving? We don't know, but that is correct. I mean, if you talk to neurology residents, they have their most migraines during their neurology residency, and then after residency, they have fewer migraines.
With that comment.
I don't know if you remember, I actually developed migraines when I was at my Kaiser residency.
Now she's program director.
She was my program director.
So I think that's an excellent point, because we're always wondering about that. And so I think clinical trials try to address that by having it sort of a run-in period where they try to see, but we don't know. Are you more likely to want to go to clinical trial because you're having more migraines at this point in life? You just don't know. It has a natural history that we know, but it's so variable for individual patients. Everybody is different.
Thank you. So I'd like to actually ask our manufacturer representatives to come to the table and also invite Dr. Ellis and Dr. Walton to also join us as we continue this